Thank you, Vairag, for the opportunity. My talk is on, is there a role of, and what is the role of reverse shoulder replacement in fractures of the proximal humerus? So let me first make my case that why reverse? Now, we all know that 80% of fractures of the proximal humerus are very suitable for conservative treatment, so a large chunk you don't need to operate. Here is a simple example of an undisplaced, I don't know how many parts you will call it, 4 or 40 parts, but they do very well with conservative treatment. So this is just to emphasize that 80% can be treated without any surgical intervention. So the real challenge is the remaining 15 to 20% of the proximal humerus fractures. And in the young, I have no dispute that we must try our best to preserve the head of the humerus. So that again is not a dispute. But the real issue and the debate is when you have a 4-part displaced fracture in the 60-plus age group. There are multiple problems, as you heard the previous speakers with huge experience, poor bone quality, tuberosity problems, avascular necrosis, and it's very hard to get a fixation on the shell-like bone of the head of the humerus. Now, this shook the orthopedic world. The PROFER trial, it is a multi-central trial of I don't know how many hundreds of cases, and it told us that there is no difference between the results of conservative treatment or operative treatment in fractures of the proximal humerus. I think it was a faulty trial. But the result of it, the trial said that there is no difference, not because the results of conservative treatment are good. It is because the results of internal fixation are not so good and often unpredictable. Here is a series of examples to make a point. Look at 1, 2, 3, 4. Many have been shown by my speakers as well. I am sure that even you have had such experiences with all modalities of fixation for, remind you again, displaced 4-part fractures of the proximal humerus, particularly in the elderly. And I can go on and on, example 7, 8, 9. So let us all admit and accept that there is a problem with osteosynthesis in the elderly 4-part displaced fractures. So if osteosynthesis is a problem, like Dr. Tanna said, let us do a hemi replacement. But there is a problem with hemi too. Let me abreast you with the latest. This is example 1, hemi, which is failed because the cuff is gone. Example 2, hemi, which is failed because the tuberosity again is gone. These are all done by fairly experienced orthopedic surgeons in Mumbai and around Mumbai. Example 3, done by me, hemi, the tuberosity has disappeared. So hemis can be unpredictable. Why? Because we are not able to get a consistent union of the tuberosities, no matter how diligent and how hard you try. It's a difficult operation. So tuberosity resorption and non-union can lead to a completely failed, non-functional hemiarthroplasty. If you look at the world literature, they say that as high as 50% of the hemis will have a problem, and hence reverse. Now, if you look at the world experience, this is from France, 66% shoulder function for primary reverse shoulder arthroplasty done for fractures of the proximal humerus. Another multi-central trial, 457 patients. And what they told us is hemi can be good if the tuberosities succeed in uniting. But if the tuberosities fail to unite, then perhaps reverse will give you a more predictable outcome for displaced fractures of the proximal humerus. What is my experience? If the tuberosity reconstruction fails, then reverse is better than hemi. However, a successful hemi, like Dr. Tanna said, it is not an operation we need to throw away in the dustbin, can give you a good result. Here is an example of a comminuted, I don't know how many part fracture in a late 50 age group patient, and this is the result of a hemi. But the problem is, it is not possible to give such a good result consistently. He likes to play cricket, and here he is bowling. And the reason is, if you look at the tuberosities, they have healed beautifully. But how to get it consistently? And the secret is treat tuberosity reattachment in hemi as a form of augmented osteosynthesis. If you make an error in the height of the prosthesis, your Lakshman Rekha is 14 millimeters, not beyond. And if the version has to go wrong, within 10 degrees. And therefore, it is difficult to achieve that. So when will I do a reverse? Here is an example, 70-year-old displaced 4-part fracture, reverse, safe, one operation. You don't want to do a second operation. Another example of a head split, 68-year-old, reverse. And the most common indication in our country is a failed fixation or a failed hemi. A Bollywood superstar's grandfather, 90-year-old. Initially, I offered conservative treatment. They were not happy, so I went and fixed it. I thought it was a good fixation. He comes back to me in 5 to 6 weeks' time with this situation. I cannot think of anything else to salvage this situation except a reverse. Case number 3, 64-year-old, 4-part displaced fracture. Somebody has done a hemi. I think it's a day 1 failure. Why? Because it is too proud. This tuberosity has to disappear, and it did. And therefore, he underwent a reverse shoulder replacement, and this is 2 years post-op. However, don't take reverse casually. Here is a 70-year-old surgeon, operated somewhere around Mumbai, unstable reverse. Another example of a 2-year post-op reverse with infection. I have to do a 2-stage revision on this reverse and a disassociation of the implant. So reverse is not an easy operation. You need experience, you need training. However, it is an important procedure that you all must learn and understand, because without that, I don't think it is possible to treat proximal humerus fractures in today's day and age group. Thank you very much.